Good evening, everybody, and welcome to our Chrysalis Wellbeing series number 6 on Postvention support. My name is Jenny Pearson. I'm a Professional Development Officer for the Primary Health Network, and I sit in the New England. The Primary Health Network acknowledges the traditional custodians of the land on which we live and work, and respects their continuing culture and the contribution they make to the life of this vast region. Don't forget you can use Slido tonight to ask any questions. Please type them into the chat box. And at the end of the session, if you could please fill in the evaluation. Our facilitator tonight is Dr. Jo Woods, and she's a GP from Newcastle. I'll hand over to you, Jo.
Thanks, Jenny. I'm looking forward to presenting, to helping facilitate tonight's session on postvention support. This session will be exploring postvention, an intervention conducted after suicide has occurred and is usually targeting those bereaved by the suicide, including family, friends, professionals, community members, colleagues and peers. These individuals may be at increased risk of suicide themselves, and postvention is aiming to increase resilience and help them cope with their loss. We're going to be hearing from 5 expert speakers tonight, and it's my great pleasure to introduce our first speaker now, Professor Mfanwe Maple, of Discipline Lead at Social Work in the Faculty of Medicine and Health at the University of New England in Armidale, New South Wales. For 2 decades, Professor Maple's research has focused on trauma and loss, with a particular emphasis on understanding risk and resilience following exposure to suicide. A focus on lived experience underlies all of Professor Maple's work, where her emphasis remains on authentically including the voices of those with first-hand experience to better inform policy research and teaching. Thanks very much, Mfanwe.
Thanks for the introduction, Jo, and thanks for welcoming me to this event. So as Jo said, my research has spanned 2 decades and has primarily focused on exposure to suicide and how people following on from exposure to suicide experience distress and support, and the way in which the community can better look to the community. So tonight I'm going to just move through a few things, hopefully to guide the rest of the evening and the discussion. So obviously from my point of view as a researcher, the language that I use is very research focused. So it's not necessarily the language that people would use in practice. So I just want you to be aware of that at the outset. So I'm going to talk about what we know about exposure to suicide to start with. Who is affected and what that effect is, and then what we know about postvention supports, so postvention being support after suicide. So I do have some slides. I figure that was probably a better way to move through the evening for you and keep you focused rather than just looking at me for the whole time. So Chris, if you would be able to put up my slides, that would be terrific. Thank you. Okay, so if you go to the next slide. All right, so this is basically difficult probably on a small screen to see, but what I wanted to point out was this is the increase of research attention in research towards postvention and bereavement. So this is a 50-year review, and as you can see across the top, there's an increasing trend. But the bits that I have boxed for you there is really to focus your attention to where the research attention has been. So primarily on exposure and through comparison of suicide bereavement to other deaths. And most of this work has been with adults. So what that helps you to realise is that we don't know very much about other component parts there. So the sorts of way in which children, young people might experience exposure to suicide, the way in which postvention services might be effective, the way in which professionals are affected by suicide, and a whole lot of other areas. So really just starting to show you that while we know some things, we don't know everything, obviously, and there's plenty more research to be done in this area to be better informed. If you can go to the next slide. So really, these are the kinds of areas that have been most focused on and what has come from the research. And so it's obviously around PTSD, around the way in which suicide notes might impact on people's understanding of why somebody chose to die. It's around the sort of social support, and then not surprisingly, the sorts of emotions that are affected by suicide, particularly around stigma, guilt, shock, trying to understand why. And if you press the next slide. So as I started to allude to, there is some real limitations to all of this. And primarily this is around sampling issues. It's very difficult to get a sample of people in any research that's been done that isn't really focused on women, particularly, as you see there, between 60 and 90% of most samples are female. So a lot of this information is limited. There's certainly not very much information from priority groups such as Aboriginal and Torres Strait Islander people, people from culturally and linguistically diverse backgrounds. There's also some issues around ethics and the way in which we can undertake this sort of research. And we also don't know who will be affected by suicide and when. So doing any sort of prospective research is really difficult. Next slide. And next again. So my colleagues in the US and I proposed a continuum of survivorship, and this really just was to help start to theorize who is affected by suicide. And this is to kind of fill some of those gaps that I was talking about. So often people think about family and friends, and logically that's who particularly GPs would most likely see in the first instance. But obviously there's also a whole host of other people who might be affected by a suicide death, also including health professionals. So what we proposed is that there is a large population of people who would be exposed to a suicide death. And then as you go through those concentric circles, you'll see that there's suicide affected, then suicide bereaved in the short term, and suicide bereaved in the long term. While this is a theorised model, it's yet to be empirically tested, and it is focused primarily on bereavement. And so therefore, thinking about this exposure to suicide as being the loss of an attached relationship. And so that doesn't necessarily explain well for us the way in which people who are often first responders in a suicide death and have many more exposures to suicide than the general population, for example, might actually end up being quite affected, but clearly not in a bereavement or a grieving type fashion. And so it obviously needs to be tested and considered more broadly. Next slide. So back in the 70s, Ed Schneidman, who was an American psychologist, who really was the first person to start talking about postvention as a way in which to support people after suicide, estimated that of the 50,000 suicide deaths that there were in the United States at that point in time, that there would be at least 200,000 survivors created from that. And the language obviously is representative of the fact that this was in the 70s. Since that time, it's kind of become common folklore that 6 people are affected by each suicide death. For those of you who have known somebody to die by suicide, or a family where somebody has died, you'll know that there's many more people often than 6. If there's a large community around that person, whereas if it's somebody who might be homeless or isolated or have a very limited social group, it may be less people. Next slide. So again, with my colleague Julie Serrell in the United States, we put together this complex formula, which actually was just as simple as doing it on a calculator once we had some information, statewide information. So we used information from the state of Kentucky, and we were able to put together a calculation to work out, well, how many people may actually be affected by a suicide death. And this was using a whole lot of assumptions from the evidence. And so on the next slide, which will actually just reveal how many people we know now to possibly be affected by a suicide death. So next slide. So 135 people are likely exposed to each suicide death. And this is a lot of people, but we don't know, again, to what effect people who are exposed will be affected by that death. Next slide. And next slide. So bringing this to Australia and trying to think about what sort of level of distress might people have experienced following on from exposure to suicide. We did a survey with Suicide Prevention Australia. So again, this was a convenient sample sent out through Suicide Prevention Australia and their networks. And we looked at the K10 as a way in which to determine the level of distress. So what you see now in the purple is the ABS National Mental Health Survey, which shows that Australians are generally low distress through to less people, obviously, at the higher ends of high and very high distress. Next slide. When we compare that with our community sample of people who are exposed to suicide, you'll see there that while still many people are at low level of distress, we are much flatter across those different groupings of distress to high and very high. Next slide. And so what I wanted to focus your attention here is in the box text there. And so those who were most distressed, not surprisingly, and many of this will just be ringing true to your own practice, are those who said that the death had a significant and devastating effect on their life that they still feel. And if you go to the next slide. What was important there also was those people who had much greater contact with the person prior to their death. So across the slide there, you'll see every few days and daily. And again, this will be confirming, just assumptions that you would hold, that there's a bigger gap in the person's life when somebody who they had been spending a lot of time with is suddenly not present any longer. Next slide. So thinking about that then, and thinking about carers, so people who are providing care to somebody prior to their death by suicide are clearly spending a lot of time and have a lot of invested in trying to keep that person safe. So in a project that we did with Sane Australia, we looked again at using the K10 to be able to compare our sample against the general community, shown there again in purple, our exposed general community members, they're in the green. And if you press next, you'll see that our carers are again even more highly distressed. So when we're thinking about this in clinical practice, obviously those people who feel closest to somebody who has died and those people who have spent a lot of time with that person prior to their death are the ones who are more likely to experience distress following on from a death by suicide. Next slide. This distress also continues over a long period of time. So just looking at where the red kind of bracket is over the purple, green and blue to the right of your screen, you'll see there that moves through from 1 to 2 years right through to 5 to 10 years after the person has died by suicide. So this is not an event that where distress is going to disappear quickly, and people are going to need support into the longer term. Next slide. So as I said at the very beginning and through explaining the samples that I just talked about, they're again limited by the people who respond to surveys or to interview opportunities. So with the University of Melbourne, we did a project where it was a random digit dial representative sample of Australians. So this gives us a better idea of who is actually exposed to suicide in the community. So that was a sample of 3,002 people. They were asked in the past year whether or not they had had any suicide ideation themselves, and then lifetime exposure to suicide and the degree of impact from that suicide death. And you'll see there in the bold that 58% reported knowing somebody who had died by suicide. And interestingly, 67 had known multiple people who had died, and the average there being 2.8. So this isn't an uncommon experience for lots of people, at least or more than half of the Australian population. We could expect that people have been exposed to a suicide death in the past. Next slide. Importantly, of those who reported that they had known somebody to die by suicide, 18.5% of them had also reported suicide thoughts in the past year. And those were more likely to report their own suicidal thinking if they had a higher impact from the death that had happened. So there is something, and many of you will be aware of the literature that relates to cluster and contagion of suicide. There is certainly something in being exposed to suicide that does also relate to people's future suicidal thinking. Next slide. So postvention is prevention. So let's have a look on the next slide at what we know about postvention services. And I know there's some great services being represented here tonight, but there is also plenty of gaps. So if we go to the next slide. Again, showing there that the little attention to interventions, and I think actually there might be another click and you'll see that come up. So there's very little across the board that has been looked at in terms of interventions, and we do need to update this. This was 2017, so the latest literature in here is from 2015. Next slide. So just having a look at some of the existing support services. So Standby, who I know are presenting tonight through the Coroners, again, presenting tonight. There's also Support After Suicide, which is run through Jesuit Social Services in Victoria and now into New South Wales, as well as there being some online different supports. And there's some evidence to suggest that these are effective and that there is some economic value in providing these supports and reducing distress. But one of the issues, again, is that it's mostly kin who do, first degree kin who do access these services. And again, it's mostly women. And so it's interesting to think then about the priority populations where exposure to suicide will be greater because there's a greater density of deaths. So again, thinking about First Nations people. There's also some emerging evidence around particularly offering postvention support to essentially closed populations, so in schools, and starting to think about the way in which those sorts of in-person and groups can support people with different needs over time. Next slide. And if you just click again, sorry, I should have taken out the extra clicks. So when we're thinking about who is most likely to need targeted interventions rather than where people have to respond to or go and help seek themselves, we're certainly thinking about those people who are kind of boxed in the purple there. So those who feel very close to the person and who have been who are in a close relationship, obviously, and those who provided care. But I'd also ask you to consider the people who are zero responders, so those who find the body, first responders, obviously police, ambulance, firefighters, second responders, yourselves as health and social care professionals and teachers, and those who identify closely with the deceased. So this might be people who may not be necessarily in a relationship with that person. They may have distant relationships but identify with them. So it's certainly worth asking if somebody is showing distress, whether or not they have known anybody to die by suicide, and to consider what that might look like for the person. And another click. And obviously there's those overrepresented groups with high exposure and priority populations, as I've said. So thinking about cultural diversity, particularly gender and sexual minority groups, where we know that suicide is much higher rates of suicidal thinking, and therefore also exposure to suicide death. But I'd also encourage you to think about the other social determinants of health and the sorts of barriers and vulnerabilities that would preclude people from reaching out to the support services that are available in the community if you're a good help seeker. Next slide. There's also obviously some evidence for the sort of impact on physical health of this sort of trauma. And so I just didn't want to go by without mentioning that, because obviously, particularly for GPs, you're focusing on physical and mental health and are well aware of the sorts of impact on physical health that trauma and traumatic loss might also have on an individual. Next slide. And I didn't want to finish the evening or my part of the evening without mentioning as well that it's not all bad news. Exposure to suicide can obviously cause distress, and that distress can be long lasting. But there is some evidence that is emerging. And again, this will likely fit with your own experience if you've known yourself to have known somebody who's died by suicide or others. that there's also potential for finding new meaning and purpose in life. And some of the sorts of ways in which people might develop new ways of thinking about the world, and that there is post-traumatic growth possibilities there, and particularly when there is acceptable and timely support offered to people. Next slide. Okay, we can just keep going through that. Yeah, so basically what I wanted to kind of point out here is that for service providers, whether you're a support service, whether you're a GP or a health professional in another discipline, it's really about trying to reduce those adverse outcomes, obviously. But we need to work in partnership with researchers, like, obviously myself. I work with a lot of the different agencies that are offering support, so that we can really understand what exposure to suicide looks like, what that impact is, and better inform policy and funding decisions, and to make sure that we're evaluating the interventions that we are providing in the community. And the next slide should be my thank you for listening, and I look forward to listening to the rest of the presenters tonight.
Thank you very much, Mufanwe. That was it was very sort of affirming, actually, the stuff that we do see in practice. So thank you. I'm looking forward to hearing the next speakers as well. And we have David Thompson, Executive Manager at Inclusion, who is going to speak next. He has oversight of the Standby Response After Suicide program, and he brings more than 30 years of leadership experience in the community care, disability and aged care, and education and retail sectors. And has spent most of his time in the not-for-profit space, working alongside people living in regions as far apart as South American Andes to Broken Hill in New South Wales. He's passionate about achieving positive social change in communities. So thank you, David. Looking forward to hearing from you.
Thank you and good evening, everyone. I'll just do a rather brief presentation to the presentation that Lisa will then bring to us. You know who I am now after hearing that, so it's good to be with you this evening. Social Futures is a community services organisation that operates across a great portion of regional New South Wales. We've been operating for about 40 years. We're a generalist community service provider, and we've actually been operating Standby Response After Suicide in partnership with Standby National across northern New South Wales for the past 8 years. We're currently expanding alongside Standby throughout Hunter, New England, Central Coast, and the northern part of Western and Far West New South Wales, and also into Gold Coast. So exciting times for us to be expanding in this area, and looking forward to meeting you all as we go about. Just for context sake, we are currently finalising recruitment, and we hope to be more or less operational by the end of July, though you'll start to see us more and more around, or hopefully start to interact with us more and more around over the coming weeks as we start to have staff out and about, and you'll have contact details for us later on. So that's just a brief introduction for myself. Lisa will have the presentation around Standby and what Standby is and does for those that don't know or those that want a bit more information. So back to, once again, our chair, I believe, and then it'll be Lisa.
Thanks, David. Yes, so we're going to be hearing from Lisa now. Lisa One is the Partnership Coordinator for Standby National, and she's going to be working alongside the preferred partner organisation Social Futures to implement the expansion of standby services within the region. She has over 20 years' experience working within the human services sector, and also has included education, disability and community services. And she's been working with the Standby National program for the past 3 years, supporting and mentoring standby teams in the standby model, and providing critical postvention support to communities impacted by suicide, which has included the Hunter New England Primary Health Network region. She's passionate about creating opportunities for collaboration between local communities, organisations and individuals bereaved by suicide to guide and inform the standby program. Thank you, Lisa.
Thank you very much for that introduction, and thanks very much for having the opportunity to come along this evening. As in the introduction to myself, we're really excited to be expanding the standby services into the Hunter and Central Coast region. So I'll just share my presentation. Just bear with me a moment. I seem to have lots of screens open, so I'll be a moment. Doesn't seem to be opening. Chris, would you be able to share the presentation which I sent through, if that's possible? So I do have a presentation prepared for this evening, so hopefully we're able to get that to everyone soon. I'd also like to recognise those people that are joining us today with lived experience of suicide. So when we talk about lived experience, we talk about those people who have thoughts of suicide, those people that are bereaved by suicide, and also those people that are also caring for people who are having suicidal thoughts as well as those people whose lives have ended due to suicide as well. It was very interesting to listen to Professor Maple, because a lot of the work that Standby does is underpinned by Professor Maple's research undertaken, as well as Dr. Julie Sorrell from the States as well. So lots of the research that we refer to is actually the work from Professor Maple and Dr. Julie Sorrell as well. So I'm just about to get my presentation back up on the screen. So apologies for some technical issues. I did try it a number of times, but as can often happen, it doesn't work when it comes to the crunch time. So Standby has been in operation since 2002, and we are the leading postvention service within Australia. We are currently working through our phase 1 expansion of the Standby program. So currently we have been operating in 11 PHN regions, and we are going to be expanding to 31 PHN regions. So phase 1, as David just spoke about, is the expansion into the Hunter, New England area. And when I get the presentation, I'll be able to show you some of the other areas which we are expanding to as well. So as has already been spoken around, postvention. So some people may not be familiar with the term postvention, but we know that the term postvention is all of the support that is done to assist those people that are bereaved and or impacted by a suicide death. We know that there are significant human and economic costs, including some of the long-term and long-lasting effects of those people that are bereaved and impacted as well. So postvention refers to all of the interventions that attempt to reduce negative consequences that may impact on those that are bereaved and impacted by suicide. And we know that to be most effective, those supports need to be a coordinated and collaborative and balanced approach as well. We know that exposure to suicide is not uncommon, as Professor Maple outlined, that over half of the Australian population may be impacted and bereaved by suicide. As well. So hopefully we'll be able to get those slides up in the next minute as well. So the main objectives of suicide postvention. So here we've got the screen here. Thank you for sharing. Could we go to the next screen, please? Yeah, so as I said, the standby program. So I think that was, yeah, so the standby program, we are informed by the research that has been undertaken. So if we can go to the next one, yeah. So we based off the research that has been done, which Professor Maple has gone through this in quite a lot of detail, just around the number of Australians that may be impacted by a suicide death. And we know that those people who receive timely support, it can reduce the risk of depression and more thoughts of suicide within the general population. Those people that have been impacted and bereaved by suicide are up to 8 times more likely to consider suicide themselves as well. So could we have the next slide, please? Yeah, so when we look at easing the trauma and related effects of a suicide loss, we look at the opportunity to be able to facilitate the healing of and support of those individuals that are impacted and bereaved, and then also look at how we can encourage that resilience and coping strategies. Looking from a strength-based approach, we are a non-clinical model. We are a community-based program. And we know from the research undertaken from our client evaluation, we know that the earlier that people can receive support, it does look at reducing and minimizing the risk of thoughts of suicide themselves as well. So could we have the next slide, please? So this is just if people are not familiar already with standby support after suicide, we are a 24/7 support service. So we're not a crisis response, but we do have, if someone wants to make a notification or someone needs to speak with a trained counsellor, we do have support 24/7 available. And that goes across, as Professor Maple said, it is to assist people that perhaps are not just initial immediate family, but also if there's first responders, those zero responders and other people who do have a perceived close relationship with the person that has died. We can offer, most of the support that we offer is face-to-face, and we can offer that support regardless of when the suicide may have occurred. We can provide that support. Sometimes people reach out, it could be decades, and they still reach out and have and want support as well. But we know that if we can get that support sooner, then that is always beneficial for those people that are bereaved and or impacted. So could we, and we also follow up people for up to 2 years, and we know that particularly around the 18 months to 24 month period from the research that we undertook was the time that people felt that they did need to have those extra supports in place as well. So this just gives you a bit of a footprint of the standby program. So all the areas that are in teal are they do have a standby service within all of these regions. We are working at the moment on the phase 1, which is your region. So we're working closely with Social Futures to get that program up and running within your area. You can see in the darker area as well that the New South Wales post-suicide support program, that's been up and running since May this year, and that's co-funded with the New South Wales Ministry as well. And then those areas that are highlighted in red are going to be expanding over the coming months as well. So our overall aspiration was to be able to offer that support, that equity of support to all Australians, and that is becoming a reality. So we hope by the end of the year that we will be fully operational within all of the PHNs throughout Australia as well. Next slide, please. Yeah, so this is just really kind of just sort of reiterating what I've just said. So we have been working with Social Futures since 2013 in the North Coast New South Wales PHN region, and as a result of that program being very well received and having a very good reputation, we are partnering with Social Futures to expand into the other PHN regions, which is Western New South Wales, and also your region as well. Within the Western New South Wales area, we will be working with two providers, one being Social Futures, which will cover the north of the Western New South Wales, and then also with Wellbeing. So we'll look at how they can collaborate and work together as well. So next slide, please. Yeah, so now that we are able to hopefully have more buy-in, having the program national and also the whole of state-based, we hope to establish more robust referral pathways to ensure that we are aware of the suicides that occur, and make sure that support can be provided to those that need that support as well. So we're looking at developing MOUs and really being able to offer that support to anyone who may need it. We'll also be having a 24/7 number, which is listed there as well. So we're going to be able to be across the whole of the state with that number as well, and that will be geo-targeted to where the person is calling from. Okay, so I might just kind of sort of skip to the end just of the presentation, because I'm conscious of the time that we have this evening. But as just to the end, please. So I think just on the final slide. But as David has said, we are looking forward to working in collaboration with all of you in the region. So we will be available to provide some training and community workshops, which we will be working with local like a local governance structure to be able to offer that training to anyone who would like to come along to the training. We would also be looking at mapping the needs and also the services and supports that are already present within your region, and we look forward to working with you, perhaps organising some shared activities around World Suicide Prevention Day, International Survivors of Suicide Day as well. So we look forward to ongoing future positive relationships with all of you as well. So my apologies at the start for the presentation not going as planned, but thank you all.
Thank you so much, Lisa. That was very comprehensive. We've got a few more questions, and I'm sure we'll get to have some opportunity to get to them later in the Slido. Our next speaker is Danny Nugas, who's the Senior Forensic Medicine Social Worker. He is working with Forensic Medicine Social Work Service in Newcastle, which is a New South Wales health pathology service, which provides information, support and advocacy to families following an unexpected or unexplained death reported to the Coroner in New South Wales. Danny has degrees in social work and in Indigenous studies from the University of Queensland, and he has specialised in grief, loss and trauma for the last 15 years. Danny is a conjoint lecturer at the University of Newcastle and invitational member of the International Work Group on Death, Dying and Bereavement. His postgraduate studies in clinical healthcare redesign research into the needs of suicide bereaved families and daily contact with individuals and families motivate and inspire him to work collaboratively and innovatively to improve systems and outcomes for bereaved people. His overseas work has included developing and delivering national programs in the UK for children bereaved through homicide, suicide and military conflict. Danny's contributions to the field of grief and loss have been published and presented internationally. We're very fortunate to have Danny in our region. Thanks, Danny. Looking forward to hearing from you.
All right. Thanks a lot, Jo. I always say thank you for that generous introduction that I wrote for myself. So I'll sit here humbly and listen to that. But really, putting all that that experience and study and other and practice aside, most of what I know and have learned and can speak with any authority and particularly passion on is what I've learned from the real experts, and that's people who are bereaved, people with that lived experience, and and I pay tribute to them. As you can see on the slide there, I've referred to my little chunk here of the webinar, which I'm really pleased to be part of, and thank you so much for the invitation. It's bereavement care as well as postvention. Those things go hand in hand, and sometimes seeing the word care in the same sentence as coronial might not always be intuitive. That's most definitely what we strive for, and in the 10 plus years of my recent social work career that I've been at forensic medicine in Newcastle, there's been a lot of changes, primarily that have been focused on increasing the family focus and support for bereaved families in the often confusing and disempowering coronial process, and it's very pleasing to be a small part of that shift, and I hope some of you have recognised that or will continue to do so in your practice and in your overlap with the coroner's process. And like all the areas in which you work in, and the health system and the service that I represent, New South Wales Health Pathology, these systems and organisations and teams are generally made up of good people who care. We don't always get it right. There's always room for improvement. There's always gaps, as Miff said. And what I espouse is a service that is proactive and dedicated to the needs of bereaved individuals and families, that pays dignity and respect to the person and the people who've died, and that contributes to systemic and structural change. And they're the RITE for New South Wales Health Pathology. So we're part of a statewide service in forensic medicine, and you'll hear a little bit more about that shortly. Those right values are respect, innovation, teamwork, and excellence that align with the values of the PHN and the professional and personal values of all of you who are tuned into this webinar in your own time this evening. I'd like to add my acknowledgement of the country and pay my respects to elders past, present, and emerging, and also to all people from all backgrounds and walks of life that are committed to being part of the solution rather than part of the problem, and contribute to better relationships and learning and reconciliation and closing the gap for Aboriginal and Torres Strait Islander people. Also acknowledge that Aboriginal and Torres Strait Islander people are overrepresented in the coronial system and in the worst of all statistics, as we know, including untimely deaths and suicide deaths and bereavement by suicide. So the coroner's role, the four questions really that the coroner has to know is when someone dies in the community and when a death's unexpected or unexplained, is who's the person who died? So there needs to be some level of identification. When did the person die? And so what was the date, and try and narrow the time frame to when they died. What were the circumstances of that person's death, and what was the medical cause of that person's death? So the cause and manner of their death. The coroner's process is inquisitorial. It's an inquiry to try and find those answers: who died, when and where did they die, and what's the cause and manner of their death. And really that encompasses any death where there's not a death certificate issued. So when there's not a GP or a treating physician who's able or comfortable or willing or available to to write a death certificate, that person's death's reported to the coroner. And so there's, in the number of deaths reported to the coroner, the largest proportion of those deaths are natural deaths, which are unexpected or unexplained, or for whatever reason there mightn't be a death certificate able to be issued at the time. And there's a triage process that we go through to gather information to help decide whether a death certificate can be issued, or whether a coroner can write a death certificate, or whether there's some level of post-mortem examination. I'll go into a little bit more detail about that shortly, but just sticking with the coroner and some of those systemic changes and shifts and improvements that have been worked towards, particularly in recent years. These were, some of the significant changes to the 2009 Coroners Act of New South Wales. As you can see there, sort of enshrined in that legislation is protecting the dignity of the deceased person, involving family members. Respect for the deceased person includes trying to determine the cause of death through the least invasive means possible, and also the rights of families to be able to object to post-mortem examinations, as well as request post-mortem examinations. So a big part of our service at forensic medicine, including the forensic medicine social work service that I lead, is making sure that families are at the centre of the decision-making process. It's clearly explained the limitations and the frameworks and the the parameters of the process and the Coroner's Act and the coroner's jurisdiction, and that the coroner ultimately makes the decision. However, families' views and wishes are proactively sought and an important part of that decision-making process. And so if we're talking about postvention, if we're talking about what are our responses to bereaved people, and we look at those concentric circles of where support's positioned after someone has died, forensic medicine is there or thereabouts in terms of first and second responders, from the death notification until the funeral, and sometimes beyond that. We're proactively involved with families, and what people want at that point in time is information and choices, and to know what's going on. So that sense of empowerment and inclusion. And the next slide shows, it's just a range of things that come to mind. Of course, all those different aspects of a death reported to the coroner may or may not be relevant, particularly for every circumstance. But there are many of the thoughts and fears and possibilities swirling in people's heads, or they're confronted with when someone dies, and even it's a very small percentage of deaths reported to the coroner where there are suspicious circumstances, and where there's going to be some level of criminal investigation. However, people's minds quite often will automatically go to CSI, or they'll be at the hospital and the person's died, and if there's a breakdown in the level of communication about what's happened, what's happening next, your mum's death's got to be reported to the coroner. That's not because anyone's done anything wrong. It's because mum died after she was in a car accident, so it's not a natural death in that respect. So the coroner needs to look at all the circumstances, and the police are the agents for the coroner. So the police will come, take some statements. They'll need to get an identification done. When that conversation, as one of the thousands of examples, if that conversation doesn't happen at that time, and the families around the bedside at the hospital, and the police are called in, off their general duties with their, all their kit and tasers and guns and everything hanging from them in full uniform. It's not uncommon in my experience for families to say, we thought that people thought that we had something to do with our relative's death. So you can see how that magical thinking kicks in for adults, not just children, when people and professionals aren't armed with correct information, and perhaps aren't armed with the time or the processes or the confidence to be able to talk directly to them about the coroner's process and difficult and sensitive things at this very painful and distressing and confusing time. And in practice, for yourselves in whatever context you work, you might be working with someone 10 years down the track, and from their bereavement, and it's important that loss, their bereavement's acknowledged, and knowing a little bit more about how the coroner's process, on top of everything else, turns the volume up on people's grief. That might help you to be able to recognise that there might be some aspects of that experience that need to be further considered, that might actually be relating to some of the difficulties in the current presentation and their life and their addictions or their depression or their family circumstances or their unemployment or whatever it might be. Now that might be related to their previous losses, and perhaps compounded by not having the information and support that they needed at the time that the death occurred. So that might be an opportunity to say, look, would it be okay to try and find out some information from forensic medicine or from the coroner's process? It might be about access to the autopsy report. It might be trying to gain access to a suicide note that was written for someone, but it's only ever gathered dust in a coroner's file. Perhaps because well-meaning but paternalistic people as part of the system thought that it wouldn't be helpful for others and taking people's choice away from them. So the next slide's maybe a slightly more delicate way than that word bomb in the previous slide to consider the intimacy and precariousness and pervasiveness of grief. My colleague in Canada, Tom Attig, refers to the process of bereavement of relearning your world. There's Bob Niemeyer and colleagues and many others that have stood on the shoulders of Viktor Frankl and his Man's Search for Meaning in 1946. And there's a lot of literature and study and theorising that's influencing practice around meaning reconstruction and benefit finding, and that can link into post-traumatic growth, resilience, and those concepts as well. And a message I'd share with you at this point in time is, and I know this can be a challenge working in health as health professionals, and with the and with that body of knowledge and those predominant lenses that we wear within health and from medical training, and also with the time restrictions as well, is not to automatically pathologise grief. We don't need to medicalise it. And normalising people's experience doesn't mean minimising it. A guy who I'll call Ray, his 21-year-old daughter died. And one of the things he said to me was, and this was catching up with him sometime down the track, and he said, I don't want to lose this grief that I've got, because that's when I feel closest to her. So there's a challenge there. Maybe it's a seed to plant, and maybe one to water and think more about that in grief, the recovery model and treatment models aren't a neat fit. So how is that reconciled in practice for you? In the next slide, there's obviously we know where we are. That lends itself to an international audience. But for your knowledge, forensic medicine is a statewide service. It used to be Hunter New England Health, but now it's a statewide service where we've got 3 forensic medicine departments. In Lidcombe, it used to be Glebe, but now in Lidcombe there's all deaths reported to the State Coroner's office. In Greater Sydney region, all the people are admitted into the care of forensic medicine in Sydney. There's a forensic medicine attached to Wollongong Hospital that covers mostly the south coast of New South Wales. For everywhere else, forensic medicine in Newcastle on the campus of John Hunter Hospital, where a separate building around the back, is where people are admitted into our care, either locally for direct admissions or from regional areas of New South Wales if a post-mortem examination is required. People aren't automatically admitted from Moree or Kempsey or Tweed Heads or Broken Hill if there's no need for a post-mortem examination done. So there's a triage process that's involved where all the information about the death is provided to our rural triage team with a duty pathologist, a clinical nurse consultant, a duty social worker, admin team, with the coroner and with the inclusion of the family, and drawing on and contacting GP surgeries and treating teams at hospital to gain hospital records and healthcare summaries to help the duty pathologist make an informed recommendation to the coroner about what the coroner's direction should be, whether a post-mortem examination is required, and if so, what type of examination is needed. And Chris, let's just skip to 2 slides ahead, please, where we've got this is what families will need to know. The previous one was just an infographic about the triage process. So these are aspects of the family's experience and what we try and support them with based on what they need. And that quote from Pamela Dix from the research that was done, the family's post-Lockerbie disaster, and from the disaster victim identification literature, said how my family were treated in those 11 days remained with me and influenced me in my life ever since. And that's an important reminder for me and my team and colleagues and for yourselves as well about the impact that we have and can have, positive and negative, through how we're able to be in the circle with people in a constructive and helpful and empowering way at these times. The next couple of slides just give you a little glimpse of forensic medicine. Please get in touch with our team if you're going to be in our neck of the woods and would like to be able to see our facility and look at all those friendly faces. So we're a multidisciplinary team, multi-agency work. We work closely with funeral directors, police, court staff, obviously yourselves, medical staff, hospitals, and we're all on the same team. It's not an easy area of work. It's difficult situations, and we're all committed to trying to work effectively and efficiently and compassionately. So I'll finish on the slide because I'm mindful of time as well. I think this presentation might be able to be shared. Perhaps there's a few more things that might be food for thought. But in the time that we've got, I'll just finish on the ripple effect slide. It's a metaphor I've been sort of playing around with for a little while, thinking about postvention, about early intervention, about prevention, about public health, and thinking about the death that occurs being the stone that drops into a body of water. and considering in your role, in my role, in our services, in our life, in our communities, where are we positioned in that body of water? It's inevitable that there will be turbulence and ripples out from that. Maybe great waves and turbulence. People, thrown overboard and struggling, struggling to breathe. But we each have a role or roles that we can play in response to a death, to any bereavement, and seeing the stone as it's about to fall in the water. If you're working in the context of palliative care and pre-bereavement work, there's a lot that can be done that can influence what ripples out, and the ripples aren't and don't always have to be considered to be negative. As other speakers have said, there can be the positive things that people can learn and can grow from their grief, as well, about meanings in life and support that they've got. And one thing I'll leave you with is that a bereavement of any type, not just suicide, even though that's the focus of this talk, and there's a significant body of research that backs that up. In my experience and in other research and literature, a death of any type is a risk factor. So to consider a bereavement, a loss, multiple bereavements, and all the other factors that complicate those experiences for people can contribute to poor outcomes. If we can do what we can with what we've got and where we are to be able to mitigate some of those effects and recognise people's grief and sit with people in their grief and really validate that, and try and link you with what services there are available and supports, and provide what support we can to people, and be part of increasing resourcing and support and better understanding for people in more compassionate communities, then we can really be part of changing people's lives. All right, that's plenty for me. Thank you for allowing me to go a couple of minutes over.
Summary of, and plenty of food for thought, and I think that will lead into some good discussion around our winding up for today, which is the case scenario. We're going to have that presented to us by Dr. James Stevens, who's the lead GP at Wellbeing, Aboriginal Community Controlled Health Organisation, which is on whose land I'm meeting on today. Jim is a GP with a long career in working in Aboriginal community-controlled health organisations through the Territory, the Kimberleys, and in the last 5 years here in Newcastle. He is having a little bit of trouble with his connection, though, so I'm just waiting to see if he might be back on. Chris, do you mind seeing if Jim's been able to get back on?
I'm on. Hi, everybody. How are you all going? Hope you're hanging on in there. I can't hear myself, which is a bit strange. Look, I'd also like to acknowledge the Awabakal people of this land that I'm standing on today. I'm not an Aboriginal person. I'm a GP. I've worked for a long time in Aboriginal community-controlled health. And I'll be talking about the GP role in supporting family. But given my background, and the fact that I think there's a few Aboriginal health practitioners and workers and some RNs in the audience, I guess it's not just the GP role, but it's a lot of people's role. And in my service, it's definitely a team effort. Danny, thanks so much for that. I found that very interesting. There's a couple of words which leapt out to me in that talk, and I think the main one was, well, there's a couple actually, but choice is a big one, and I'm just going to let that hang there for the moment. We've got a few the case studies, got a few questions that are sort of posed to a GP, but I think we can consider them as opposed to anyone who's involved with bereavement care, supporting family. And the first question in the case study is, what factors do you consider when a person presents who is bereaved by suicide? And I think I'm going to just throw a few things out there from my perspective, and I think Joe might interrupt me and ask for some input from the rest of the panel. And I'm sure some of you would like to throw some questions up there on the chat box as well. And I guess, so for me, what factors would I consider? I can really only talk from working in an Aboriginal community-controlled health perspective. And so the first thing first factor that I consider is that in the community that I work with, and all the communities I've worked with, trauma of many kinds is an ongoing thing for people and family and for community, and suicide's a part of that, and it's a big part of it in Aboriginal community, and particularly although I'm not sure what the exact evidence for this is, but certainly in young people. Other factors that I consider, there's a concept called the ripple effect, which has kind of been talked a bit to tonight, that idea that it doesn't just affect the one person, the family, but the community broadly. And the more connected the community, the more connected, the bigger that connection in the group, the more people that are affected. And I think Van Way talked pretty clearly about the statistics around that. And I think that's definitely backed up anecdotally by people that I know and work with in Aboriginal community-controlled health. Things like ripple effects like suicides, multiple suicides in one community, one after the other, following, particularly young people, lots of mental health stuff following on from that, and other things like alcohol and other drug following effects, physical effects, definitely things like, and again, it's anecdotal, but I think, things like people, all those cortisol, stress hormones, things like cardiovascular issues. Dr. Alex Brown's done quite a bit of research in how depression and things like that in Aboriginal community definitely is we think is a risk factor for those sorts of things, as opposed to the common ones we talk about. I guess the other factor that I consider is, well, actually, maybe this should be right up the front, is what are the persons in the community's protective factors, and I guess the other thing is that where I work, there is actually very low trust in mainstream services, and so we have to be mindful of that. And I guess the other thing more broadly is that there's a lot of shame and fear around suicide in Aboriginal community, and I'm not sure how that translates, and maybe people can give us their perspective in the mainstream community, but certainly, and a feeling that there's a lack of skills and confidence to talk about it, and quite a bit of silence around the issue. So it's a topic that people are often reluctant to discuss. Fear, when we're talking about fear, when I mention fear, there's that fear of forced removal around suicide. So intergenerational trauma and forced removal of children, stolen generations, all these sort of these things then translate and echo through into the community's fear of mistrust of authority. But that's all I'm going to say about that first question around what factors would you consider. Joe, would you like to open that up to the rest of the panel and see if there's any comments from them?
That's a good one. So just the sort of background case scenario. Sorry, Jim, I think it might have, I was assuming you might read it out, but I think it got lost when you were a bit disconnected. So a person attends your practice, they've been bereaved by suicide. This may not be the main reason for attending your practice, however, it's impacting on their health. And you've gone through, the factors and all of those things that you would consider in that presentation. And I should have invited a bit more enthusiastically the listeners to see if they have any contributions to questions and get them to add their thoughts in. Do we have, I'm going to actually throw this open to the panel. Given your experience, Danny, in particular, perhaps I might ask you, if we have somebody that's sort of a bit undifferentiated like this, do you have any particular recommendations about how we should be approaching that as GPs?
Oh, thanks, Joe. I think I might start just by linking it to what I would do in my role. Obviously, I'm not, it's a different context, not a GP context, but then seeing what translates then to what is relevant and possible in the GP surgery. And I think this is probably, useful information for the attendees to know about. The things that I consider and want to know about when we've got information about, and including the family contact details about a suicide, is who's the legal senior next of kin. We need to know that for the coroner. A lot of the information we get from the police is sometimes not that detailed, because it's as much as what the police can gather in a very short time frame within 24 hours that they've got to forward onto the police. So they're restricted by that, and sometimes police don't have the knowledge that we've got around the Coroner's Act and the need to know that it's the legal senior next of kin. There's a clear hierarchy about who that is. Has the formal identification been done? What do the people know about? Has the death notification occurred? What do the people know about the death? How long ago did the death occur? And these would be questions that might inform your assessment in a GP surgery, in your practice, in your context. What do they? And I often start by saying, "What do you know? What have you been told?" And then trying to help people piece that together and to guide my assessment of people's understanding of where they're at and where their gaps of knowledge are. And then from that, you can get the hooks to what do they really need? So in this scenario, it might, be wholly dependent on whether someone presents to the GP surgery and their close relative died yesterday by suicide, indicated to be by suicide, or it might be the anniversary of their death, and the death might have occurred some time ago. So it mightn't be, they won't at that time be saying, I need to go to find out what's happening. I want to be able to see them. I want to be able to say goodbye. I want to, I'm told they left a suicide note for me. So I suppose in that context, as part of the assessment, part of that initial response is to say, okay, what do you know? Find out what's happening for that person, and having an awareness of some of those aspects of of those those sort of broader processes that are put into action, particularly around coronial processes and forensic processes, and some of those aspects that turn up the volume on people's grief when they're bereaved by suicide, to guide what your response is going to be at that time. I'll let others add to that, Joe.
Thanks, Danny. And just reflecting on some of the points that Jim made too, I think whilst time is often used in bereavement to say time heals all wounds, it's not particularly useful way to think about this. But what we can think about is that in the very immediate aftermath of somebody dying by suicide, the needs will be very different to further on down the track. And obviously in that immediate time, there's a lot of trauma, there's a lot of chaos. So that they're the factors that are most presenting. But then over time, what we've found in our research, and I just recently did an international survey of people that are experts in this field, whether as service providers, people with lived experience, or researchers, about when people will need different responses and what sorts of responses they are. And so, as Lisa also referred to, there's particular times well into the future. So whether it's beyond that immediate chaos into the next step after that, where it might be 3 to 4 weeks down the track, One of the things that we've found a lot is that people talk about the way in which they feel like it should be getting easier, and it's not. And that's often also when people are starting to notice that they have other physical ramifications of being in trauma. And so, and from this sudden death and the associated impact. But then obviously at 12 months, and then I think Lisa mentioned 18 months, and certainly into time on after that. And particularly if there's another death, and that's where I'd just like to highlight, I guess, what Jim was talking about in relation to Aboriginal communities and highly cohesive communities where exposure to suicide and suicide deaths are happening much more regularly, as well as other suicide attempts in the community, which can stir up some of those factors again. So I thought I'd just add that on to thinking about time and where the person is up to and how those risk factors and protective factors might be there, who else is around them to support them, and do they need further referral onto specialised services like standby, for example. Back to you, Jo.
Oh, yes, I just wanted to quickly add as well, we're not prescriptive in the support that we provide to individuals who are bereaved and impacted by suicide. But one of the recommendations that we do say is that it's always good to check in with your GP and get some general health checks undertaken. Because we know from the research that those people that are bereaved by suicide are more likely to consider suicide themselves. So really just
I think we might have just lost Lisa. If I can get some confirmation. Chris, have we lost Lisa? I'm not sure if you've lost me. Lisa, I was actually really looking forward to hearing a little bit more about how standby fits into it and how proactive it is in terms of referral. Is it sort of reliant on a GP recognising somebody is suffering from acute grief related to a suicide and referring on to you? Or is it something that can, with all those sort of multi-organisation connections that you have with the coroner's office and all of that sort of stuff, something that will happen spontaneously, and we can hope that may be happening ongoing for the patient? Back to you, Lisa.
Yeah, Lisa's still not with us, so she must have had IT issues. I can answer that one, Jo, for everyone. Yeah, there's no need for a GP referral. We're happy to take referrals from anyone in community, so anyone can actually refer on, and that's normally what will happen. So it may well be our first responders, ambulance, fire brigade, police, or whoever they may be. As we network better across the region, we'll be making contacts with first responders, so they're aware of the service. But also it may be, if it impacts areas like a school or something like that, it may well be the principal of the school or someone. So anyone can certainly reach out. Family members do it all the time as well. Once they get to hear of the program, they're referred through, or people who are impacted can self-refer through. So we don't demand a GP referral or anything like that in the slightest. So it's an easy no wrong door access. We actually had a team in Armidale last week supporting an event there. So we're not actually rolled out there. We sent a team from northern New South Wales into an event there. So already currently dipping into the region a little bit to help out. Back to you, Jo.
Thanks, David. We'll just throw it one more time back to Jim. Is there anything else that you would like to share about following up clients as well, Jim? Otherwise, I'll move on to showing some health pathway stuff.
Yeah, hi, thanks, Jo. Well, I think, there's a couple of, there's two other questions. There's the follow-up one, but there's also how do you approach this situation? What's your first step? What actions would you take to support this person? We've talked a bit about that. Look, all I wanted to say is that a couple of key points there. it's about relationships, really, isn't it? We all know that, and GPs and nurses and Aboriginal health practitioners are often the people who have that relationship with that family, with that bereaved family. So we're in a really unique position to be useful. It's, I think, really important to approach things from what I know is a trauma-informed care approach, which sort of starts with, has 4 kind of key pillars: listening, developing trust, giving the person the control of the situation, and working on choice, and at people's own pace, and really, avoiding judgmental language and body language and those sorts of things. And when we're refer to trusted services and to people, and organisations that are safe, I think that's really important. Joe, do you want me to move straight on to the how do you follow up with your client? I'm just mindful of time, or do you want to go back to the other team to further discuss that business, or you lead on that?
I think we've sort of been covering that a fair bit in the discussion. Why don't we go on to the final one, and then we can throw it back to the panel for final comments. How does that sound?
Sounds good. All right. So the last part of the case study, and apologies for not doing the intro, I completely forgot. I just leapt into it. How do you follow up with your client? Well, there's a lot of things in that, but I don't know. The first thing that sprung to my mind is don't make promises, that you can't keep, because people who are experiencing, trauma are pretty vulnerable, and I think that's pretty important. So follow-up is absolutely important, and getting as many people as that person, wants around them is the key. And I really, it's up to the family and the bereaved person to set the pace and to decide how that follow-up should go. But certainly being present. There's a few things. I go to funerals. I know that's a bit of a sort of a, people have lots of different opinions on that. Again, make sure those referrals are trusted, and follow up on those referrals, I think, is very important as well. And I guess ask around with your contacts. What I would always ask Aboriginal staff what's best from here, kind of thing. If they're able, if the person has allowed them to be part of the care process. There's a few resources that are useful as well, and a few referral pathways. But I might just hand back to you, Joe, to talk about.
That's flicked back. Just wanted to give Lisa an opportunity to finish what she was trying to say to us before, and then give the panel one more opportunity to their final comments. So, Lisa? All right, we still don't have Lisa on the camera. Miff, did you have any final comments around those sort of patients that come in with other reasons, but definitely have had exposure to bereavement through suicide, to try and maximise the opportunities for postvention?
Sure. So I might actually just slightly change that question a little bit, Joe, just to give Standby a bit of a wrap on a part that we haven't really talked about. We've talked very much about individual interventions, and clearly that's what most of the audience will be involved in. But Standby also do a lot of community development and work with service providers across each area to look at where those referral pathways are and how best to use them, so that we talked about some of that chaos if a family doesn't know where to go. And so really having a look in your own community, whether there's a community postvention team there, and there'll be somebody in the community who's the lead person on the Standby, where there has been that community development done. That works really well, and so it was good to hear that there had been that, obviously in Armidale. I'm aware of that event, and knowing that those sorts of pathways are really clear so that people don't fall through the gaps. And that's obviously one of the biggest challenges. It may be difficult to get an appointment with a GP. It may be difficult to understand the service system if you haven't already done that. And so when everybody else in the community knows what part of the services they're going to provide, it can really help out. So I just wanted to also highlight that Standby also have that fantastic kind of wraparound in addition to the individual service provision for people. And certainly they can provide advice on that to a GP or a health professional from an area who might not be aware of other people in the community who are working in support after suicide.
Thanks, Miff. I think that's what I was hoping to hear from Lisa. But I think she might actually be back now. So just a quick opportunity, Lisa, for a chat.
Yeah, so sorry about the technical issues that I've been experiencing. I'm currently in New South Wales delivering training for the new people that are going to be commencing work in the region. So I'm sorry for the technical issues that I'm experiencing this evening. I'm not sure where I cut off last time, but I just wanted to just to reiterate that one of the connections that we always recommend that people make is to go along to their GP and to get some general health checks undertaken, not to pathologize people, but just to get some of those just general checks, because we know the impacts of the shock and trauma, what that can have on an individual. But also to when they do go along for that additional added safety, so that the GP is asking those people if they are perhaps having thoughts of suicide themselves, and if they are, because we know that people who are impacted and or bereaved by suicide are up to 8 times more likely to consider suicide themselves. We encourage them to go along to the GP and for the GPs to ask that question sensitively to those people that are presenting. So that was what I just wanted to reiterate, just about the importance of people checking in with their GP. So thank you, Jo.
Thanks for the plug, Lisa. No, that's great. Danny, did you have any final comments?
Thanks, Jo. General final comment: if as doctors, nurses, ALOs, mental health professionals, service managers around the coronial pathway, in any respect, if you're not sure, call us. There's a duty pathologist, on call round the clock. We're here to help and work together. With regards to the case scenarios and final thoughts, I'd probably, and particularly thinking bang for your buck in postvention, is ask about the children. Who are the children in this family? That's where a lot of early intervention preventative work can have great benefit throughout life. And all of you will have had patients and known people who've been bereaved as children who didn't, with all good intention, they weren't given choices, they weren't included, there was no honest information given to them, and you know what the outcomes were there. So we have an opportunity, and I'd say a responsibility, to gently challenge and provide the information and resources and evidence around the importance of including children and finding ways to do that. And there's a lot of resources, a lot of information that that Jo's got an email that I sent. So that would be probably my big plug. There's a lot of gaps there. I've come from the UK working with the National Childhood Bereavement Organisation, running national programs for children bereaved through suicide and other means, and it's a big gap over here that I'd like to be part of filling in some way at some time if people want to be part of that. But that'd be my final messages, and and thank you, and keep up the good work, and take care of yourselves. We're not much use to anyone else if we're not working sustainably.
I think that's an excellent point to finish on, actually, Danny. So self-care and thinking about kids. So this is the bit that I'm going to finish up on, which is my bit, is where you go, I can't remember all of those things and I can't remember how to refer to everywhere. So you can always come back to Health Pathways. And just for those of you who aren't familiar, it's a fairly standard setup for all of our pages. It's Community Health Pathways, username HNE Health, and the password is Pathways P1TH W1YS. And there's 3 pathways that I wanted to bring to your attention. There's a bereavement pathway, a suicide ideation and intent pathway, and a medical practitioner's health pathway. The bereavement pathway and the suicide ideation pathway both have the standard setup with background, assessment, management, and in management point 11 here we have some postvention support information. So if we're trying to remember who was that chap, Danny, that's right, he was at the Department of Forensic Medicine. How do I get in touch? Here's his phone number. Well, actually I think that gets through to the counselling service. There's the standby support and after suicide phone number that we've had Lisa talking about for today. And there's also the Thirley National Indigenous Postvention Service. So that's an Indigenous specific service there as well. There's lots of other good online resources to use. Don't expect people to be able to remember all of these things, so just know where to find them. I think that's the important part of it. The bereavement pathway has a small section that Danny maybe would like to check out at some time to see if we can flesh it out a little bit more, but on support for children there as well. Medical practitioners' health pathways was spawned out of some unfortunate suicides in our medical community as a way of trying to be a bit more proactive about medical practitioners' health. It's got some resources for self-directed care as well. So if people who are listening today have some concerns about their own health, that might be somewhere to go and start. But of course, the most important thing is to go and see your own GP. Wonderful. So that's the health pathways bits and pieces that I wanted to share tonight. And I think that brings us to the conclusion of our talk. Just wanted to very quickly thank all of our speakers and really appreciate their sharing their expertise tonight. I think it's a very important area and something that we can never talk about too much. So that's wonderful. Thank you.
Thanks, everybody, and thank you, Jo. You did a great job facilitating tonight. Just before I go, we will have a copy of this recording on our website under our education tab in our library, and a copy of the presentations. Thank you very much, and we'll see you next time.
Talk about forever, talk about the weather, to know any better. I just want to laugh until I can't breathe.